talk, I'm going to cover a very simple approach to general anesthesia, which is a complex process with a lot of moving parts. And I don't think any specialist anaesthetist can ever use exactly the same recipe because patients and procedures vary so much. And the recipe may need to change even within the same procedure, just as the patient's condition changes. But I will end this talk with a recipe that's as close as I can get it to a beginner recipe that will work and will be safe, even if it's not the most elegant anesthetic in the world. Now, I want to encourage you to develop a new skill sets. And the first one, I know it sounds very basic, but being disciplined about doing a pre-op evaluation is one of them. It's an area where district hospitals have the clinical skills and the tools necessary, but it sometimes gets neglected because of busyness or task sharing. Like one person books the patient and another person anesthetizes. And if you're a beginner anesthetist, it's vital that you do a good pre-op assessment. So don't fall into the trap of anesthetizing an unassessed patient. It's something you can control, and that assessment defines which recipe you will use. We are then going to go through how to prepare equipment, drugs, and staff, the process of anesthesia with induction, maintenance, and emergence, and then the importance of the recovery period. We're obviously going to focus on anesthesia in this talk. Now, it's important before you commit to the procedure that you pause and just check, are you the right person doing the right procedure in the right place with the right team? And can you improve any of these things? Do you need seniors or more hands? Sometimes that's all it is, an extra person in theatre. Do you need equipment that you could get to? Should you do this in the daytime? Should you make a phone call or even refer the patient? And it doesn't need to be a long pause, but sometimes we forget that there are resources available even in the institution where we are, or that referrals possible in stable patients that might not be possible later once you started operating. And it's good to just pause and think your way through this procedure. Come back to examining. It doesn't have to be an exhaustive examination, but make sure you do a general assessment. You listen to the heart and lungs. In particular, pay attention to the heart rate and whether there are murmurs. You examine the airway in those 3 areas we've covered before, which is the ability to do mask ventilation, the ability to do effective laryngoscopy, and then whether or not you can do rescue airway. So you look at front of neck access. Then you want to check the vital signs, heart rate, blood pressure, oxygen sats, what's the respiratory rate, the level of consciousness, and the temperature. And these are basic things. You can do them anywhere that you are, and they're actually very good predictors of outcome, especially respiratory rate and level of consciousness. In terms of investigations, usually you don't need a whole lot of things. This could just be a ward hemoglobin or a glucose, or maybe even a blood gas if you've got access to a blood gas machine. And then as part of the examination, remember to think about why we are going to theatre. So if it's for something like a low-lying placenta or a previous Caesar times 2 or 3, are you dealing with a patient with placenta accretus spectrum? And you would prepare differently or even refer that patient while they're stable. The second skill set is preparing properly. And again, this is just because it's something you can control. And you've won a lot of the battle if you induce an assessed patient in a prepared environment. It's a discipline, but it's vital. Just the patient condition and the patient procedure, they alter the way you prepare your theatre in many ways. And that theatre setup includes staffing, equipment, drugs. Draw up the drugs you think you will need, not just have them available. So if you think you've got an unstable patient, it's much better just to draw the adrenaline infusion up before you start. And are there expected complications that you can prepare for? So if you've got a placenta accreta that's going on into theatre as an emergency, 2 lines. Is there blood available? Do you have FDPs? Those sorts of things you can prepare. And remember, if you're looking to find them on this YouTube channel, there's emergency drugs, airway trolley checks, how to check a machine. And something that I teach repeatedly is that always make sure, even though you've checked your machine, that you've got a working ambu bag which you've checked. You've got suction, and that suction works, so a Yankauer with a working suction machine, and that you've got a spare oxygen cylinder. Because when you don't have those things and your equipment fails, it's very difficult to fix that. Now, when you're going to do an anesthetic as a beginner, You're always feeling overwhelmed already by all the new things you have to watch for. So try and look after yourself by working out in advance all the things you can do in advance. So work out the doses that you're going to give. Don't try and think of them on the fly while the patient's asleep. Have everything ready. You don't find that you have to fix things or find things that you could have thought about before. Use checklists. You're allowed to cheat. Use things on the wall that you've stuck there. And if you need to, bring a friend or phone a friend, just to get that cognitive load down so you can focus on the important things. General anesthetic is very simple in concept. You're going to position and pre-oxygenate your patient, and you're going to use a checklist, which are increasingly useful in preventing adverse events. You're going to induce the patient and then put an airway in that's usually intubate and ventilate. You're going to maintain the anesthetic, and at the end you're going to switch off the maintenance and take them through emergence. And that's the basic phases of anesthesia, but the one that seems to get everyone a little nervous is this induce, intubate, and ventilate. And it is a high-risk time because you're giving the drugs, you're then managing the airway, and then you have to manage the complex machinery of the ventilator. So find ways to practice that phase in particular. Use mannequins if you've got them, or during resuscitations, make sure that you practice intubation. When you've got people coming to your hospital that can anesthetize, try and get general anesthetics on the slate. And with the ventilation, use a false lung on the ventilator and set it before. Practice changing between the modes on a false lung if you're not sure how to use a ventilator. So find ways to practice what scares you. Now that's a false lung or a test lung. If you haven't seen one before, and you just put that on the end of the circuit and then you set the ventilator and you ventilate it. Now, because you're all in district hospitals, I can see you all shaking your heads and saying, well, we don't have one of those. Well, there's some other things you can use. You just put one of the bags on the end of the circuit or even a glove, and you can ventilate these things and practice the different modes so that you understand how to move between the different ventilator settings. And again, it's a controllable, it's easy to do, so make sure you're not learning how to set ventilators with a live patient who's asleep in front of you. Now, this was an article from an article that myself and Simon Leroux from Global Surgery in Cape Town wrote on anesthesia for a ruptured ectopic pregnancy at district level. The reference is there, except that it's 2024, not 2004. Oh, it's 2021, sorry. And this is how to do anesthesia for a ruptured ectopic pregnancy when you're trying to have a formula. So if you're interested, get hold of that chart, put it on the wall in theatre, and follow these recipes for anesthesia, and then just adjust as you learn. But this will give you some tips for the different phases. Remember that the ESMOE guidelines have the drug doses in them. Again, I've distributed those, but take those guidelines, laminate them, stick them up on the wall in the theatre where you are, and remember you're allowed to look these things up. You're not expected to know these things off by heart. And again, you can check the videos for emergency drugs. There's also on each phase, I've done a series on how to ventilate, how to intubate properly, the obstetric airway bundle. So go and learn the basics well, because these things you're doing every single time you do a GA. Now, I just want to say something about positioning before you go to sleep. It is so important. And again, the more of a beginner you are, the more important this is. You should position patients as if they're going to be difficult intubations every single time you intubate. Now, if you look at this person in the schematic, if you try and intubate this person in this position, you're looking down into the mouth, as that arrow shows you, but you're actually trying to see at right angles towards the vocal cords, and that's not a great position. So what you want is you want to get the mastoid process in line with the sternum, or the external auditory meatus in line with the sternum, and look at that position now. When you look into the mouth, that red arrow showing you're going to be looking straight down onto the vocal cords. There's other ways to get this position. You can you can lift the bed and then break the head of the bed, like that many of the beds allowed. Anything that gets you that side on view. Notice there's two things. The one is that the angle that you look at the vocal cords is better. The other thing is you can see the thyromental distance has increased. So you've made that area below the chin nice and long, and that's always a good sign. It means that you've put the airway in a good position. Get that airway like that before you start. Pre-oxygenate properly. Look at the seal on this mask. It's tight. Either time yourself, or better still, look at the machine. You should see a nice capnography trace, which tells you there's a good seal. But also you should see inspired oxygen approaching 100%. And you should wait until that expired oxygen is better than 90% or 0.9. 0.8 is probably acceptable, but aim for as high as you can. And your machine does have this measurement. It's a mandatory measurement in South African anesthetic machines. And people often say, I don't have that. It's somewhere on your machine. Otherwise, your machine wouldn't have been able to board. So just look for it. It'll be somewhere. You have to have gas analysis. This buys you time if you pre-oxygenate well. And again, it's one of the controllables. So if the patient has an airway problem, you're going to have 4 or 5 times as long to manage that problem. So this is a discipline. Do it properly. And then you're going to choose which induction agent you want. And for the recipe that I'm talking about, I've picked ketamine because it works in just about every scenario. But of course, in the stable patient, I tend to use propofol. It's a smoother induction, and it's a smooth awakening as well. But I've put ketamine in this recipe because whether the patient's stable or unstable, it tends to behave the same. It's only in the very unstable patient that it's not a good idea. You then pick something to paralyze the patient. If you're intubating, succinylmethonium again works for rapid sequences and for elective sequences, but you might choose rocuronium if the patient's got an empty stomach. And then in maintenance. And again, I've chosen isoflurane in this example, but if you've got sevoflurane, it's absolutely fine as well. So that can look as simple as give ketamine and succinylmethonium, maintain with isoflurane, and then set your heart rate targets to under 120. Try and keep the blood pressure above 90 systolic and the hemoglobin above 7. And that's how we take you through a ruptured ectopic, but in the stable patient, those aren't bad things to aim for either. And that'll get you through a basic general anesthetic. Now, to manage the airway, you can obviously intubate, or you can use a supraglottic airway device if the patient is starved. I'm just going to go through briefly endotracheal intubation today. It's very important to get your technique right. If you're unsure, just have a senior there and tell the patient's on the ventilator. And just having another experienced pair of hands really, really helps when you're in this situation. If you look on the slide, there's a link to an instruction guide on Airway Jedi. I found this really useful. They talk through all the techniques, and even if you think you can intubate, you often learn things when you read other people's descriptions. The important things here are that when that laryngoscope's in, that's the direction that you pull in. It's up, up and away. You're not rotating the wrist, which is a thing we often do, especially when we're struggling a little bit. And the other maneuver that's really, really helpful is the burp maneuver, which essentially means that you press the larynx backward, upward, and to the right with pressure. So you can almost imagine you're pushing it back into the throat, but also sort of to the right, almost up at the right ear, so that the larynx the vocal cords move into view when you're doing laryngoscopy. So you take a view that looks like this, and when you push downwards to the right, that's what you see. And I'll tell you that just about every intubation I do, I'm using a little bit of this. Even if I can see nicely, I put the vocal cords into a better position. So get used to using the burp maneuver. You can take an assistant and you can actually move their hand and then say, hold it there, and then you intubate it. And it makes difficult intubations very easy. And then I'm just going to run you through basic intubation technique. This is going to be a little bit rushed, but essentially start with a curved blade. It's more forgiving of imperfect placement than the straight blade. And then remember, it's a stepwise progression, and each step has a goal, and you need to accomplish that goal before you move to the next step. So you open the mouth and insert the blade, making sure you don't damage the teeth. You do a tongue sweep. and advance the blade. Now, if you're seeing tongue on the right side of your blade, you haven't swept the tongue properly, and you shouldn't advance. You need to sweep that tongue over to the left. I'm going to show you an example just now of when someone hasn't done that. You then identify the epiglottis, and you get the tip of the laryngoscope at the base of that epiglottis, which is called the vallecula. And you are not allowed to lift the laryngoscope in that up and away method until you've got your tip right at the base of that epiglottis. It's really, really important. Only then do you lift up and away. Then you try and identify the arachnoid cartilages and the cords. You use a burp maneuver if required, and you watch the tube go through the cords. Don't lose sight of the vocal cords. If you do, if the tube obscures your vision, you actually often slip underneath the arachnoid cartilages and you go into the esophagus. So this is a video clip of a laryngoscopy. I'm just going to talk you through the process. So here the blade is going in. That tongue sweep is not very good. You see this tongue on the right side. They should actually move it to the right and sweep it across. But they found the epiglottis, and that tip is in the right place, and that's in the vallecula. This intubator now should have lifted up, but instead they're playing around a little bit more, trying to get a better position. And then while they're doing it, they go past. Now they've lost the epiglottis. Now you can see the arachnoids and the vocal cords, but when you go past it, you won't be able to lift as effectively. So you put it in that right position, that's fine. So now you have got the tip in the right position. They've lifted up and away, and you can see the vocal cords and the glottis. Now you can bring the tube down, obscures the vision slightly, but then you can see it going through the cords. You can see the bottom of the arachnoid cartilages, and then what we all do when it's a difficult airway or you're a bit nervous, you push it too deep. So this operator is now pulling it back. There's the second black line, and you know that you shouldn't really go past that. You should have also taken notice of where the balloon was, and that the bulb of the tube just needs to go past. And that's how you do an intubation. So the most important thing I can stress there is that that tip is in the right position. It's a thing that beginners often get wrong. Then you move on to the ventilator. Pick one mode that you like. The easiest one to understand is volume control, which is not the best mode. It's not my favorite, but it's the easiest to understand. So I recommend you start with volume control, and once you've got that sorted, you move on to pressure control. And you would set something like a tidal volume of 400 mils. It's actually something like 6 to 8 mils per kilogram, a respiratory rate of 12, PEEP anywhere between 5 and 8, and an oxygen level once the patient's stable of about 40%, FI2 of 0.4. If you've got them, use synchronized modes, because then when the patient starts to breathe, the ventilator will support that attempt at a breath rather than fight the ventilator. So once you've intubated, you manage the airway, you set the ventilator, but just remember that the goal is oxygenating and ventilating, not intubation. So if you can't get the tube in, put a supraglottic airway device in. It's completely acceptable. Just make sure you can ventilate the patient. So don't persist with attempts at endotracheal intubation until you end up in a cardiac arrest. You have 2 or maybe 3 attempts. If you fail, you put in a supraglottic airway device. Maintenance can be done with isoflurane or with sevoflurane if you're using a volatile, or with either a ketamine infusion or boluses. I tend to use isoflurane because it's the cheapest, but remember it's a range, and it depends on what condition your patient is in before you decide on the dose. If you're going to try and use ketamine for maintenance, the patients often are moving even while they're under ketamine. That's that dissociative effect, and you sometimes need to use a muscle relaxant in combination. Remember that the amount of maintenance required is dependent on the patient condition. So sicker patients need less, and patients can be well and then become sick under anesthesia, in which case you need to lighten them, or sicker patients that are perhaps being bleeding, as they get resuscitated, they may need more. So the one factor in deciding the dose is how well the patient is. The second is how much stimulus there is. What is the worst stimulus, and are you deep enough? Have you got enough maintenance on to deal with that stimulus? So more pain, you need more gas. But a very, very important part of general anesthesia is to remember that pain can be treated with analgesia. So a key component in GAs is that if you treat pain aggressively, you need to use less gas, and then you sometimes end up with a hemodynamically more stable anesthetic. So a moving patient who's moving in response to pain could be treated with analgesia. I would always deepen that patient, give them either propofol or more gas, but then I would treat the analgesia, and you might find that it was the inadequate analgesia that was the problem, not your depth of anesthesia. So for analgesia, the one that everybody knows is morphine, 0.1 milligrams per kilogram IVI. Give paracetamol intravenously if you've got it. But if you're not sure and you don't want to use something that's so long, fentanyl 1 mic per kilogram every 20 to 30 minutes is an excellent analgesic, and it wears off very nicely, provided you don't give massive doses of it. So use those things. And if your blood pressure's if you've got so much gas on that it's dropping the blood pressure, perhaps what you need to do is treat analgesia better and back off on your gas a little bit. And it's a thing that in the beginning, we often are scared to do properly, but it really makes for better anesthetics if you treat pain well. And then I just want to say something quickly on emergence. Patients should be hemodynamically stable, not on adrenaline infusions, oxygenating well on not a massive amounts of oxygen. You want a hemoglobin that's at least over 6, ideally over 7, and a temperature over 35, although most guidelines would want you to have it a bit higher. If you've used a non-depolarizing muscle relaxant like rocuronium, then you need to reverse, and I've put the doses of glycopyrrolate and neostigmine, and you give those together. Remember, if you give the reversal of neostigmine on its own, you're going to get those anticholinergic or antimuscarinic side effects of bradycardia. And then as a general rule in the district hospital, I recommend awake extubation, not a deep extubation. How do you extubate? Think about how you do this in your setting. Are there people in the room? We tend to have lots of people around at intubation, and then everyone leaves when you extubate. But the complication rate at intubation is 4%, and at extubation is 12%. So during the period of much higher risk, there are fewer hands around. And that's a mistake we often make. When you extubate the patient, remember that you want the lungs filled with air. So if the patient's awake, tell them to take a deep breath in, deflate the cuff, and extubate it at end inspiration. If you're still using the bag a little bit, you give them a big squeeze on the bag, fill up the lungs, and you pull it out. That's because then, if there is any airway secretion that falls onto the cords, they're able to cough that out. If their lungs are empty, all they can do is breathe it in. And then don't forget the recovery period. It's the last good time that you monitor patients in district hospitals. So keep them there for 30 minutes at least. Wait till they're fully consciousness, hemodynamically stable, not actively bleeding, respiratory rate's okay, pain's controlled, nausea and vomiting is controlled. And if you are forced to discharge one of those patients that's a little bit on the border, make sure you plan a post-operative visit. Just go and see them in a couple of hours' time and make sure they're all right. It's such a good way to check that patients aren't slowly deteriorating in the ward. So I hesitate to do this because in practice I almost never give an anesthetic this way, but if I had to tell a beginner over the phone what to do, this is the recipe I'd give that person. Ideally though, if you're needing a recipe, you phone someone and they'll talk through a recipe that fits your patient. But what would I do in all patients? I would examine every patient and prepare every theatre. I would put monitors on and a working IV line. I'd position every patient as if I was going to have a difficult airway, and I would pre-oxygenate for 4 minutes. I'd give an induction agent. In this example, I've picked ketamine, and use succinylmethonium if it was a full stomach, or rocuronium if it wasn't. I would intubate with a size 7 ET tube or a 7.5. It's usually 7 for a female and 7.5 for a male, but you have to look at the patient. And I would ventilate to keep the end tidal carbon dioxide at somewhere between 4 and 5. That's on the lower side, but if you keep it at that range, they won't start breathing against the ventilator. So I tend to use lower CO2s. I'd maintain anesthesia with an isoflurane of about 0.8, and I would treat pain aggressively while I did that. In your setting, I'd probably use morphine and maybe some ketamine, although the opiates like fentanyl and sufentanil are probably better analgesics. At the end, I'd switch off the gas and extubate awake. And just before I did that, if I'd given a non-depolarizing muscle relaxant, I would give reversal, make sure the patient was reversed before I pull the tube. And that's my one-size-fits-all recipe. Remember that the patients are continually sending you messages while they're on table. Their heart rates and blood pressures are telling you things. How sensitive they are to drugs are telling you things about whether they are sick or well, or in pain or not in pain. And it's very important to adjust these recipes to what the patient is telling you. So that's a basic general anesthesia. For the details of specific elements of the general anesthetic, I'll be covering those later in the year. And good luck with your first general anesthetic.